That is some pretty good timing, yo. What's up? It's Brad Montgomery. I've missed you. How are you? Have you been washing your hands? You know you have. I have. Not just because it's what we do during COVID, but because I was a little insecure because we have a doctor with us right now. Please welcome to our virtual stage. Welcome to your laptop, to your kitchen, to your bed. I'm not judging. It doesn't matter. This is Dr. Wendy Dean. Dr. Wendy Dean is in the house. How are you?
Hey, I'm good. I'm
I'm
really
so glad
good.
you're here. I'm so glad you're here. There we go. Hold on. What's going on with that? There we go. Boom. All right. So, Dr. Wendy Dean, I have known this smarty pants for a long time. You started
Let's
me
can we not do the math?
okay, well, let's
Don't do
not
the
do the
math.
math.
Do the math.
7 months ago, you started out in emergency rooms, but you've gone a long way. And the first question is, are you a practicing doc right now?
I am not. I haven't been practicing for about 10 years.
Uh,
Um, I left my psychiatry practice and went into more administration.
so my chance of getting some oxycodone is slim. Is that what you're saying?
Yeah, pretty much none.
Oh, curses. All right. So you run the moral injury of healthcare.
I do.
It's not about burnout. Tell me about who you are.
Yeah. So I practiced for probably 10 years. And with training, I was in clinical medicine for about 15 years.
Hmm.
And what I realized was it was really hard to take care of patients the way I wanted to take care of them. And I tried all different kinds of ways to take care of patients the way I thought they needed to be cared for.
Hmm.
And eventually I got to a point where um, I couldn't do it. And so I left clinical medicine and I went into research management oversight. And then I realized that the people that I was seeing, even in research management, were not happy. Like they were really struggling. And so I started this nonprofit to say, let's fix healthcare and make it better for patients, easier, because, what I hear all the time from patients is it shouldn't be this hard to get good care.
Mm. Yeah.
And what I hear from doctors all the time is it shouldn't be this hard to get good care. And so that's what we're trying to do is make it easier for everybody to get good care.
Yes, please. I would like that. I'll take better care. We're going to jump into that, but Wendy, here's what I've learned. I ask a series of rapid fire questions to my guests at the end of these interviews when I first started, and you and I are gonna try doing it at the front. So here are the
Great.
rules. Should you choose to accept them, I'm going to ask you some questions that really don't have much to do with your expertise. I just kind of hope you'll answer without thinking, because our goal is just to know you better as a person.
Bring it.
What are you watching on Netflix right now?
Oh, ooh, great question. Well, we just finished Queen's Gambit. Is that on Netflix? I don't know if
Oh,
it's on
that is
Netflix.
so good. The chess one.
It was
Yeah.
really good.
Is there a guilty pleasure show that you watch that you don't always tell everybody?
Oh, you know, Outlander. Like you got to watch
that
Outlander if you love
that
Scotland.
that is
I'm,
a
I
guilty
watch it.
pleasure.
I watch it mostly for the landscape, not so much for Jamie. But when he shows up, it's okay.
I think he's part of the landscape. I started watching that a little bit, and someone described it to me, or that genre. The idea was it's ambiance television. It's the kind of TV that you don't have to be fully engaged with. If you miss a little dialogue, you didn't miss anything. It's comforting.
Yes.
Good for you. Um, Tell me a little about what's your favorite candy.
Oh, Scottish tablet.
What is that?
No question.
Scottish
So it's
tablet?
kind of like, yeah, it is tooth achingly sweet, but it's nutty. So it's kind of like a dry fudge, like really dry fudge.
Yeah.
Um, but it's nutty and it's creamy and it's buttery and oh, and it goes really
Scottish
well with
tablet.
whiskey.
Can you just go into Kroger and buy Scottish tablet, or
No,
you make it?
or you buy it. You go online. You can go online and get it.
Scottish tablet is. What about your favorite beverage? I have some pre-existing knowledge here. What's your favorite beverage?
Whiskey.
Scotch, I think, right?
Because it goes with Scottish tablet.
Yeah, Scotch whiskey. So, is there a? I think you're a connoisseur. Is there a particular bottle you're drinking that you just love?
Oh, Bunnahabhain is my favorite. It's a little bit peaty, it's a little bit smoky, but not over the top with either one.
Buddha Haven. All right. If we get in your
Mhm.
car right now and the stereo comes on, what are we listening to?
Podcast.
And what are we talking?
Oh, it doesn't matter. All kinds of different things. Like I don't know, anywhere from Preet Bharara to Terrible Thanks for Asking to Fresh Air. I'm all over the map.
All right, good. Favorite pop group?
What's pop? I don't know. No, oh no, no. Vampire Weekend.
Oh, that's embarrassing. I don't know about Vampire Weekend. Tell me, what genre is that? Is it straightforward
I
pop?
don't. I probably not. I don't know. I don't know genre. It's my kid introduced me to them 4 years ago. I can't get them out of my head.
Oh, so when
Yeah.
I asked you about favorite pop, you said, "What's pop?" Do you have what's your favorite music genre? Maybe I'm not close.
I don't. Uh, I don't know. I don't know. I don't know what pop is. I don't put them into genres. That's the funny thing.
Well,
I
when's the
just say,
last
"Oh,
time,
I like
Wendy?
this one."
When's the last time you said, "I'm listening to music now"?
I have been really bad about that in the pandemic. Not nearly as much because I used to listen to it in my car all the time. I don't go anywhere. Like I
Ah,
literally don't go anywhere.
yeah. It's funny. I was telling somebody else the same story, but I asked my dad just like 2 or 3 weeks ago how he was doing, and he's 85, and he was talking about how he's listening to an opera, which is his favorite thing, and this soprano just hit this high note, and it made me laugh, and it made me so happy, and I found that to be kind of inspiring because I'm like you, where I feel like I generally win when I listen to music. It helps, and yet for some reason I'm not.
Yeah, I'm forgetting to do that.
Are you a doom scroller? Are you in the on your iPad all the time?
So, because of my work, I tend to be on social media way more than I would like to be. Um, it's a great place to get a lot of information and to connect with a lot of people and to talk about things and understand things, kind of manipulate the information,
Right.
bounce it off of different people. So I do spend more time online than I like to.
Oh, come on, admit it. You're watching cat videos like the rest of us. Come on.
Now and then. Mostly it's horses though. Mostly horses, not cats.
Because yeah, I think are you a horse owner?
I am a horse owner and I'm a sheep owner, and I ride other people's horses too.
Do you ride your own
So
horses? Because you live on a farm,
I do.
so
Yeah.
you have. We're talking about where you live.
Yeah. So I'm on 13 acres. I live on a 200-year-old Pennsylvania farm. Um, and I have my horse is retired. So she's just kind of a lawn ornament that's pretty. Um, and I'm kind of casually shopping for another one, but I can't commit. So
So that's what you mean by riding other horses, because your current horse doesn't want to be red.
yeah.
And what is the name of this lawn ornament? But by the way, if you give me $1, I will not tell your horse you insulted her by calling her a lawn ornament. What's her name?
Oh no, she'd be quite happy with that. She loves just being in the pasture. That's like horse heaven. Her name is Tara, and she's big, a big giant red mare.
Tara the land or the lawn or ornament.
Yes.
How do we feel about Taylor Swift?
I have no opinion. I don't know enough about her.
That is fair enough. That, by the way, is my girls who are now young women loved Taylor Swift when she first was when Taylor Swift was 15 or whatever she was when she got famous. So we're a Taylor Swift household.
Got it.
Tell me about a time that you did something really stupid, like really stupid. Don't think, like a dumbass thing.
I'm trying to decide which one to tell you. Gosh. I think probably, oh, I don't know. Probably the last thing I did was I broke my finger picking up a log. Not putting it down, not dropping it, picking it up.
Um, what? How do you break?
Yeah,
How
I
do you?
know. That's what I said. It was heavy. It was big. It was heavy. It twisted my finger and yeah. But that was not a good story to tell.
Yeah. So what
If you
story
break your
did you
finger,
tell?
have a better story.
Well, yeah, I trust that you made one up, right?
I didn't. That
You,
was yeah.
so
I never
honest.
think about that. Yeah.
Favorite type of hot sauce?
Oh, sriracha.
Sriracha, right?
Definitely sriracha.
It's so funny because it's such a famous hot sauce, and I've never owned a bottle of sriracha. It's worth it.
Oh yeah.
All
Yeah.
right, better than Tabasco.
Oh yeah. Better flavor.
Dr.
Smokier.
Wendy Dean, what's a bad habit that you're having trouble breaking?
Being, a couch potato.
Is it exacerbated by a pandemic?
Oh yeah. Much worse.
Yeah, yeah. I
But
find
I mean I've got miles of road out in front of my house. I could just go get on it. I just don't.
yeah. Well, I like you more now, just because me too. Just I'm not saying I didn't like you before. It's just kind of nice to know when people like you that are just so highly credentialed uh, are like me. That's nice. Tell me about the first time you realized, no thinking, first time you realized, dang it, I'm pretty good at my job.
5 years ago, maybe. Oh,
Oh,
okay. Qualifier.
good.
Which job? I've had a
Okay,
lot.
well, let's tell me about the 5 year one, and then we're going to go back early in your career to you're like just getting out of med school. But what
Oh,
happened 5 years ago?
yeah, no. So, 5 years ago was when I finally figured out how to like pull together all the data that I needed and then put it um, into a package that could do my argument for me. When I got to that stage, then I was like, okay, here we go. And when I learned how to be strategically curious and ask those questions that maybe nobody thinks about, they're kind of so simple that they're obvious, but then nobody thinks to ask them.
Strategically curious. So wait, you're good at your job. Just 5 years ago, you figured out like a secret with data or a shortcut. Is that what you're saying?
I just feel like I got good at it where I could consistently pull together the arguments that I needed. And part of the issue with that is that I changed careers so many times. Like I changed jobs uh 5 to 10 years, every decade, pretty much. And so you only get, when you're in a job for 10 years, you're pretty good at it, but you're not really good at it, I think.
uh, Dr. Wendy, the ADD of medicine, Dean.
Pretty much.
Yeah, I hear what you say. Let's go back. Well, but I am curious. What about when you were young, a young adult, just coming out of starting your first career? At what point did you say, "Dang it, I don't suck. I'm pretty good at this"?
Yeah, so it was probably 5 years in. Because I think when in medicine is the stakes are pretty high, even when you're not in the emergency room or in the intensive care unit. And so you have this weight of responsibility that every decision that you're making, somebody's life depends on that, or somebody's well-being depends on that. And it gets, um, until you can be really confident that those are always the right decisions or almost always the right decisions, um, it's hard to say, yeah, I'm good at this. And I think you just need some time under your belt being out on your own to be able to trust that. And so it was probably 4 or 5 years in that I started to trust it and say, okay, I think I'm doing way more good than I'm maybe
Right.
putting people at risk.
Yeah, it's so interesting. I never had thought about that, but it feels to me like most humans have some degree of imposter syndrome when you first start out doing anything. But when you're in an emergency room, you don't have time for that indecisiveness that imposter syndrome creates, at least in me. So that means for 4 years
Yeah.
you were kind of faking it.
No, I think what it means is that for 4 years you do a lot of checking your data, checking your learning about the things that you're going to be facing, so that when you are in the situation of needing to make an immediate decision, you can at least rely on the data. It might not be automatic. And I think when you start to feel like you're really good at your job is when it becomes automatic. You don't
Hmm.
even think about the data anymore. You say, this is what I know is the right answer.
I never had a job like that. It- does that influence the rest of your careers? Then you became you're a wife, you're a mom. Does that decisiveness where in the emergency room ICU, you're like, we're going this way because we don't have time to think. We're going this way. Does that? It must affect all of your life.
It does. It does. I mean, uh, I think it's it's softened at home, but it's not gone. So I know what kind
Yeah.
of car I want. I know what kind of, you know, part of the reason I can't get a new horse is because I know what kind of horse I want. I'm not going to settle. Um, it
Uh,
also it does translate into riding, with the horses.
right.
I Yeah,
So are you totally type A?
yeah, pretty much.
And
I'm not I'm not I'm not anxious, the sort of anxious type A, but I'm really driven.
there's got to be some downside of that because I imagine when you're talking about human relations, s- other people are less driven, maybe, and yet you love them.
Yeah, so, I have to be aware that my standards for myself may be ridiculous. And so maybe I have to hold other people to not quite my standards because I probably should hold me to not my standards. Um, it does get intense, and I'm aware of that, and I try to, soften it with humor, with whatever.
I think it works. Because you're delightful, and some intense people are not delightful, right? So come on, you know them, you know them as well as I do. They're just, they're not fun. They're not fun to be with.
Yeah, well, so, when I was a surgery resident, we were on call every third night, right? And so there was the potential that you were either on call, you had just been on call and up all night, or you were going to be on call tomorrow night,
Right.
right? So on call, pre-call, post-call. And that means that if you were paying attention to your call nights, then you weren't going to do anything outside of medicine. Nothing. Because you were either too exhausted from having been on call last night, or you needed to get a good sleep tonight so that you could
Right.
be ready for tomorrow night. And a small group of my fellow interns and I made a pact, and we said, if anybody asks us to do something on a night when we're not in the hospital, we have to say yes,
Mm,
because otherwise we're not going to have a life.
right.
And I think I've kind of carried that philosophy just through my life, is that you got to commit to fun too. It can't just be all intense and work and that.
Enter Scotch whiskey.
Well, that helps. That does help. Yeah.
Well, let's get to your current job, organization, project, passion. What in the heck?
Yeah.
I didn't know about it until I started reading about you for this interview. Holy cow, this is so cool. You have bitten off like a lot. You didn't just nibble. You're going to fix healthcare.
Um, I'm gonna try because it's really broken, It's really broken. And I will say I did not do it intentionally. I think if I had set out to build this organization and change healthcare, it would have failed miserably. What I did was I wrote with my colleague Simon Talbot a paper that was kind of a thought experiment. It was just like, okay, so this is what we think is the case in healthcare, and this is
Mhm.
why we think that people are clinicians in particular, doctors, nurses, physical therapists, why they're unhappy. Um, and we wrote this article. It took us 6 months to find somewhere to get it published. Stat News, to whom we are still grateful, published it, and it took off like a rocket. Like we seriously thought that it would get thrown in the trash with all of the other burnout articles that were coming out, and we started getting emails, and they haven't stopped, with people saying, "This is the language I've been looking for the last 20 years. This is what my experience has been in healthcare." Um, we're at 300,000 downloads of that article. Like, it's crazy.
Yeah,
And
you
go
went
ahead.
viral.
Yeah.
So,
Yeah, by
so
accident.
I read about the article, but I didn't read the article. Can you summarize it for us muggles?
You're the second person who's used that term in the last week. I love it. Um, so so moral injury is the sense that you are being asked to go against what is a deeply held belief. So in healthcare, that is the oath that we take to put our patients first as a priority always.
Right.
And then when we're in a situation where we're asked to choose something other than that, and we feel like our hands are tied because we made this promise to our patients, but we're being asked to choose this other thing, that's where we go at risk of moral injury. Um,
And what is the other thing? I'm guessing you're talking profits or bureaucracy, or what are we talking about?
yeah, it tends mostly to be the financial framework of healthcare. So we're being asked to, but it's a lot of things. So we might be asked to pay attention to what the insurance company will pay for, or to do a prior authorization, to get permission to treat you in the way that we think is best. It may be that we can't refer you to a specialist because that's outside of a network.
Mm.
Um, it's as simple as when we're in the exam room and we're paying attention to the computer screen instead of looking you in the eye, instead of making that connection with you. Any one of those things we could get over if it happened on occasion. But when it happens day after day, week after week, month after month, um, it amasses into this sense of, who am I in this system? I came to healthcare to take care of patients, and now I'm taking care of all of these other things that are getting in the way of my taking care of patients.
Yeah. Well, first of all, you have apparently been in my doctor's office watching my doctor type. Because, yeah, that.
Everyone. Hmm. Everyone. And
How
you
does.
know what? It hurts him. It hurts him to do that.
Yeah, so. And, like, so what is that typing all about? Why? What the hell is going on there? Is that because I'm assuming it's because they need to type all the stuff into the electronic records, and if they do it after my visit, they'll get behind. So they do it as they go. Am I close?
You're spot on. You're spot on. And sometimes it's because the medical record won't let them, like, they have to do it at the time. It's not like, so doctors, what they used to do is they used to see you and then go out and dictate,
Right.
right? They would dictate their note. And now, exactly. And that's actually pretty quick and pretty efficient. Um, but now the medical record requires that you answer certain questions in the midst of the encounter. Have you asked about seatbelts? Have they gotten vaccinated? Have they done this? Have they done it? It's a little bit like having a toddler in the room that's constantly interrupting and asking questions. Um, so
And that's just
it's
literally a function of the software they bought, so it's like Epic or whatever, and they can't control it.
Right. And you yeah, it's a very complicated mess, but it basically is also um, all of that typing determines how you bill. So all the typing is required to generate a bill for you that goes to your insurance company. Um, and of course, the certain documentation is required to maximize that billing so that your hospital, your health system, your practice gets paid what what's commensurate with your effort. But it's a lot of documentation required to prove
All right.
what you did in that exam room.
Well, let me ask you this: why do we care? And here's what I mean. So I hear you. Doctors are unhappy because they're not doing the core thing of taking care of people, and that's bad for doctors and it's bad for patients. But extrapolate. What does this mean for America and the world? Like who?
Yeah.
Like
So
aside from the fact that it's hard for you and my doctor, like why do we care?
because it matters to your health, because it means that your doctor can't actually engage with you. You may be somebody who cares about your health, but they don't have time to tell you why you should care about something else.
Hmm.
They don't have time to tell you why, or me, thank goodness, why we should get up off the couch, right? Even though it's a pandemic. Um, they don't, you know, so when doctors aren't able to engage with patients, that's why we went into medicine, to build that relationship, to help heal you through the medium of that relationship. And when we don't have that, it starts to degrade our feeling of meaning and purpose. And what I'm hearing more and more from physicians is that especially in the context of the pandemic, um, when we're putting so much at risk, we're starting to wonder, is it worth it? And then what ends up happening is if people leave, the shortage of healthcare providers gets even worse. So access to care goes down.
Mm.
Um, that's my big worry, is if we don't fix this problem and make it more sustainable for clinicians, we're going to lose more of them.
In your article that just blew up, I told you I read about the article. I got the impression all the docs read it and went, "She's describing me. This is what's happening." So you're describing this problem, but did in the article did you guys come up with an antidote or suggestions?
We didn't at the time because we were simply defining a new condition.
Hmm.
Um, and so we didn't even know that that was true. Now, since people have said to us, yeah, we think that that's true,
Hmm.
we've gone back and said, okay, great. Now, how do we fix it?
Uh,
And really, the things that people are saying is we want to be heard. We want to have a voice. We want more autonomy. We want more latitude. And we want to be partners in co-producing healthcare, meaning we don't want to be told how to how to run a clinical encounter. We want to be working with the administrators to decide what the best way is to do that.
okay, I was taking notes and I still got lost. The first part, I think, is every human need. Everyone wants to be heard. Everyone wants to have a voice. And right now,
Yeah.
I'm hearing from you, physicians are not feeling that way. But I think the last thing you said was that docs are feeling like they're working against the administration to get things done. And you want is it? But they want to be partners. Could you give me that again?
Yeah. So so right now, I think the easiest way to think about it is the house of medicine is divided into two sides. There are the clinicians who take care of patients, and then there are administrators who take care of the organization itself.
Right.
And each one of them is doing their level best to take care of what they're in charge of. The problem is that sometimes those things are in conflict. And so the administrators might say to the clinicians, you need to do XYZ. And the clinicians say, right, but that's not that interrupts my this patient. What's best for them? Are
All
we
right.
still?
No, I
I
got you.
look like I'm frozen. Okay.
You were
And
frozen just
and
for a
so
second.
then
I
okay.
got you.
And um and so what ends up happening is we lack a little bit of curiosity on each side about what the other person is experiencing. So the administrators think they understand what the clinicians are experiencing, but aren't relentlessly curious about that. And the clinicians think the same about the administrators, but don't understand what, may not understand what the real pressures are on the administrators. And so I think we need to work on being more curious about each other
Hmm.
and what the pressures are, because I think if we listen to each other, we can help solve problems more easily, more quickly.
All right. So, that's good. By the way, sounds good to me. Sign me up. Help me though. So, I'm assuming if I own 15 hospitals in Cleveland or whatever, and I call you up and say, Wendy, I read your article. We need you. And if you go in there and tell their docs and their administrators, you could be more curious. That wouldn't kill you. They're gonna say like, "Is that it?" Like, because every doctor is gonna go, "Well, I already am curious," because that's what, right? They're gonna say, "We're part of your team, Wendy. We're not the problem. We're curious." So how do you not get stuck?
So you put them in a room. I mean, first you talk to each side and you understand what the real challenges are.
Hmm.
And then it's really a matter of saying, you know, administrators would do well to follow the clinicians for 24 hours.
Mm,
And clinicians would do well to shadow administrators because they're two different skill sets. They're two very different skill sets.
right,
And we need to respect that. We need both sides. One without the other just isn't going to fly.
right.
Um, and so we need both sides, but we need them to understand each other. And the other part of that is that when you talk to clinicians, they'll come up with a laundry list of things that are wrong, a lot of which are workflow issues, are administrative um, work issues. And if we can just if both sides can work together to streamline those, you have happier clinicians, you have more efficient practices, life is better.
Mm,
And patients don't feel the bumps in the road as much either.
right.
It's smoother for patients too.
That last bit reminds me of Lean Six Sigma. Is that what we're talking about? Like having somebody come in and say, like, Look, it's a process. Fix the process, and you'll be better off."
So people do use some yes, it can be lean. Um, lean has gotten a little bit of a bad name because ended up it's resulted in some of the challenges that we have. But I think approached in combination with the clinicians,
Mm.
it can make a difference. And that's really, um, that's really where all of this needs to happen, is with the clinician involved, with their voice.
All right, so let's say we got a new administration coming in. They call you and say, "Dr. Dean, bring your bottle of scotch and come to Washington. We're putting you on this horse." What what are you gonna do? Like, it just feels to me when I hear you talk, it feels so overwhelming that I don't know where to start. But I think you do.
So it is overwhelming. if you take the whole thing at once. And the the solution to that is twofold. One is when the as Don Berwick said, he is a guru in um, patient safety and healthcare change. And what he said was, when you have an insoluble problem, you make it bigger. So rather than looking at just healthcare, you look at healthcare as a sixth of the economy, and you say, okay, is this enough to get it? Is this enough to get us to a point where we need to decide on some changes so that we can shift some of that sixth of the economy to other things that need attention?
Right.
So that's one. The other is you make the immediate changes personal, local, and possible. What's the pebble in your shoe? So, when I go into an organization, you say, what is the pebble in your shoe? You ask everybody that. And then you figure out what's the biggest pebble. What is the pebble that the most people have? You fix that. Then you move to the next smallest pebble and you fix that. And eventually you have, number one, a change-minded organization that's comfortable with making those changes. And then number two, you get people paying attention to what their challenges are and learning what the steps are towards fixing it. And the important thing is to develop a culture where the administration can hear that feedback.
How possible is that? Because that sounds, I mean, in perfect Wendy fashion, you've summarized it, and you made it sound not overwhelming and pretty straightforward. But how hard is that?
Change is never easy. It requires champions who are in the organization. It requires leadership to buy into it and to lead toward change. But I also think the pandemic has shown us that the way we've done things hasn't worked. That healthcare was broken in a multitude of ways, and it left us really vulnerable in a crisis. And we probably shouldn't continue with the way we.
Oh, dang it. You just froze right at the last. We should continue with the way we did things, or what did you say?
Yeah, that. That we shouldn't continue with the way we've been doing it that got us into this trouble in the first place.
So, you know that I'm a speaker. Years ago, when President Obama was President Obama, and not former President Obama, I was at a medical conference, and they had this outside speaker come in, and he was like you. He just had a ability to see big, complex issues and articulate them in a way that we all could understand. And the thing that I remembered most about him is him saying, "You know what? Every portion of Obamacare is not controversial. We all pretty much agree." And then it got political, and then we pretend like we disagree. What, aside from the politics, what is the hardest part about creating lasting healthcare policy? Is it just politics, or are people really fighting over this?
I think it's mostly politics. I mean, I think one of the challenges in healthcare is that we are all we're all trained to be very independent thinkers, and so we struggle with accepting somebody else's ideas as being good enough.
Mm-hmm.
We always think that maybe we could tweak them a little bit better. And so it's a little bit of perfect is the enemy of good. We want everything and we want it perfectly, and really that doesn't exist. And so we don't want to compromise, but that's the only way we're going to get anything done. And I do think that too much is political right now.
Am I mixing up two different things? I just brought up Obamacare. I see that in my own little kindergarten sense as being totally what you're talking about. You're talking about fixing healthcare. Healthcare for all sounds like fixing for healthcare. Are they related at all? Like, do you have to kind of scrape everything off and start new and figure out a way to support your docs better, or is it? Am I completely confused?
So I think Obamacare is the reimbursement side of it, and that does have something to do with how physicians have to practice.
Right.
Um, I don't think the US can tolerate kind of scrapping everything and starting fresh. So I think whatever we're going to do is going to have to be some revision of what we have. Um, and I do think that some of the challenge that physicians face right now is that there were requirements, expectations, um, regulations, legislation that went along with Obamacare that um, we've been asked to live with that have been hard.
Mm.
Nobody anticipated it. It wasn't malevolent. Nobody set out to design a complicated, highly administrative system, and we can change it. But we have to have the will, and we have to be able to articulate what isn't working and ask for the change.
I kind of thought with Obamacare, if we go back to that guy who was talking, who said, actually, we kind of agree on this. There's not much that we. It seems obvious to us. If that's the case, then it seems like one of the answers is doing what you said. Just kind of be at peace with it. We're going to make changes. It won't be perfect. No one's being mean. No one's trying to screw you up. But we're going to have to keep screwing it up until we screw it up, fix it, screw it up, fix it. Is that right? Do I have that right?
Until somebody comes along with a much better plan with that I haven't seen. Yeah, I think that is the way to go forward, is to accept that this is the best we can do right now, but also, hold that dialectic that we're doing the best we can with this, but also that we probably have the ability to do better.
Right.
We just need to revise as we go. Learn the lessons and make change on that basis.
So really, because a lot of what you were talking about with you being unhappy and the hundreds of thousands of fans of your article saying me too, a lot of that really is related to reimbursement.
Yeah.
By the way,
Yeah.
when you're me in my job and you're on stage in front of a whole bunch of docs, reimbursement is the punchline to every joke. I swear,
I
you
bet
can
it
say
is.
like, "Why did the chicken cross the road?" Reimbursement. It doesn't make sense. The physicians will go, "Ah, brilliant! Ah."
Yeah. It is. So I say uh, now and then that my biggest frustration is the Friedman doctrine, which says that a corporation's only obligation is to maximize its shareholder profit. And I think that we could probably talk on on a global sense about how that has changed our society. But it's also true in healthcare that um, if we could think beyond profit, and if we could get comfortable thinking about healthcare and reimbursement in a different way than profit,
Mm-hmm.
um, we'd probably be better off.
Does
Now
that
that
mean
doesn't mean, I'm not saying that we shouldn't think about money and everything should be available to everyone.
right?
Um, but I think we really need to think about how we pay for healthcare and what it means for us in a different way.
Let's make this super personal. Um,
Okay.
how do we manage the healthcare system? So I'm hearing from you, without a doubt, the system is not working for our physicians, and you're telling me, without a doubt, it's not working that great for the patients. When you, as just a human or a mom or a friend, when you're managing or navigating the healthcare system, what do you know that we don't know? Like, what would do you find yourself saying, "Oh, I get this, so I can get to where we need to go better"?
I've I struggled too. I mean, I Um, I have had occasions where family, my husband got very ill, and navigating healthcare was incredibly hard. Incredibly hard. Um, the advantage I have is I know what levers to pull to when things are, to hold people's feet to the fire.
Mm.
Right. I know that risk management exists. Um,
Well,
I have
back up. What is risk management? What does that mean?
so risk management are the people who are trying to keep the hospital from getting sued.
Oh, and so how do what what are you alluding to?
So my husband was critically ill, and I was trying to get him transferred. I had texted a friend and said I need a bed, and he had said okay. But 5 hours later, my husband was still not on an ambulance, and I was worried that if he didn't get on that ambulance that night, I wouldn't be calling for a referral.
Mm.
I'd be calling a funeral home.
Oh,
And so I got on the phone with risk management and I said, you have two choices. He's out of here by midnight, or I'm going to go to the media. Because that was the, that was the only thing I could do differently than someone else. I had tried everything I knew.
that must have been terrifying.
It was enraging. It was absolutely enraging. He's fine. We got him down the road. He left before midnight. But it left me thinking, what about my farmer neighbor? What
Right.
about all of my other friends who aren't in healthcare who don't know to do that? Um, and that's when I started thinking, this really has to change. This isn't just about the doctors. This is also about the care that patients are getting.
Yeah, it's so sobering because here you are, somebody you know the English language. You're not intimidated by people in like in places of authority, so they're doctors, right? We're supposed to listen to doctors, or they're the administrator, whatever. And it was hard for you, and it just makes you worry about those people who maybe English is a struggle, and maybe they are intimidated by people with MD by their name.
Right. Right. Or anybody in a white coat. They're not going to question. Yeah. I mean, it does really worry me. And I want the folks who are in those positions taking care of patients to be well supported, to be, um, you know, to not have barriers between them and the care their patients need.
Let's talk about your organization. You're a nonprofit, but
Mhm.
turns out lots of people. You said it's working. You told me before we started recording that, hey, guess what is happening? So tell me about that.
Yeah, so we started, when the article took off in 2018, the summer of 2018. We were getting so much feedback, and people were asking, "How do we join? What can we do?" And so we set up this organization as a way to kind of catch all that and to organize it and to help people understand what we were doing and what we were thinking about. Um, and over the course of the last 2.5 years, we have grown. We are testifying before the New York City Council about safety in emergency rooms. We're talking to healthcare systems about how to support their providers. Um, we're giving talks to help spread the word and to
Mm-hmm.
help people understand it's not about them. It's about healthcare that's broken, and let's think about ways to change it together. Um, and we're doing things like, just this year, because of the pandemic, right? There was a lot of things that we had to change. Like going out and speaking wasn't going to work so well. Um, and what we started a podcast because people were exhausted by reading, and they didn't want to watch videos, but they could listen to a podcast while they were commuting.
Mm.
Um, and so we're doing that.
And the podcast, who's the audience? Is it for muggles or just docs?
It's for everyone. So what we're trying to do is give people a window into what healthcare is really like. Um, and just our last episode was a friend, neighbor whose wife also had a healthcare crisis,
Mm-hmm.
and it was about his journey and and how how he wants to change
Right.
things, what it was like for him. So
Let me peek behind the scenes in the
it's everything.
podcast. What does the so you started the podcast during the pandemic?
Yeah. Yep,
So what
we
does that look
did.
like? Are you how what's the technology and how do you do that? And you told me that you don't love technology
Yeah, I don't do it.
or at least this type of stuff.
Yeah, so yeah, no, I'm not great with technology. So we have somebody who helps us. We have a producer who manages all the tech pieces. He's amazing. Dave at Widget Studios. Shout out to you. You are fabulous.
Hey Dave.
And he's in Denver.
Oh nice.
He's in Denver now. Yeah, he just moved. So
And he helps
and
set you up with fancy microphones and recording gear.
well, we've got good enough gear that I mean, he's a sound magician, so he just makes it sound amazing. Um, and we every couple of weeks we set up, Simon Talbot is in Boston, I'm in Pennsylvania, our guests are who knows where,
Right.
um, and we connect through the internet.
Good for you.
And
What's the name of the
yeah,
podcast?
moral matters.
Oh, I'm so glad to hear that. So I was giggling. Back to the Wendy is not only awesome, but she's intense, which I guess is why you're awesome. I was giggling at the word moral injury. I just love it because it's such a big thing. You're not saying like, oh, we're talking about resilience or burnout or whatever. You're going moral. Fantastic. That had to be a
Well, so that wasn't our term. So that's
oh
a term. Moral injury is a term that actually was coined by folks who were working with veterans who had post-traumatic stress disorder. They're being treated for that, but they weren't getting better.
mm,
And so they came up with this concept of moral injury, that part of what happened in the course of combat is they were asked to do something that transgressed deeply held moral beliefs.
oh
And that was the challenge, that they hadn't quite reconciled that part of their experience. And so
got it. So I see. There's a little bit of this. Well, it's still awesome
and
that it's
it
so powerful.
yeah, and I mean, it's a little uncomfortable for us because we're not saying, people will say, oh, that's you know as Don Berwick also put it, that's kind of a stiff-necked phrase, moral injury. Like, we're not saying that my morals are better than yours, but there is sometimes this sense that doctors have lost the sense of who they are and their sense of right and wrong. Not in terms of shall I take advantage of this or not, but um, I knew coming into it that my goal was to take care of patients, and now I can't always do that to the extent I'd like to. What does that mean about who I am?
Right. God, it's just mammoth a mammoth topic, and but we
Does
don't
your
have
head
forever to
hurt yet?
we it no, not even. Let me ask you a couple of random questions as we wrap this up, and then I'll tell you what the closing question is going to be, so you can let that marinate. I'm going to ask you what gives you hope. And you get to define that. So that might be hope in the pandemic or hope for healthcare. It might be hope for your family or that horse that you've ignored in your pasture. It might be hope for which bottle of scotch you look at next. I don't know. You get to define it. There's no rules. But I wanted to ask you two random questions. First of all, teach me the language, because are doctors doctors or are they physicians, and why do we call them doctors but always in an organization is like we talk about our physicians, we don't call them our doctors. Is that just me, or what's going on with that?
Yeah, so it depends
They're
on what country
doctors.
you're in.
Oh.
Yeah, it depends on what country you're in. But the challenge right now is that um, there are so many other clinicians who are also getting the title of doctor, that it can sometimes be confusing. So there
Oh,
are doctors who are nurses, there are doctors who are physical therapists, um, meaning, you know, people have a doctor of physical therapy or they have a doctor of nursing. Um, and so I think doctor in the US has taken on a slightly different meaning. Physician is those of us who are MDs and DOs who went to medical school, who did residency, um, who have a very prescribed training.
right. Dang it, that was a good answer. I didn't think of that. Right. All right.
There you go.
So related to that, as we record this, Dr. Jill Biden is being harassed for using the word doctor when she is a doctor of education. You're a medical doctor. What's your take on that?
Why don't we call it doctor of medicine, doctor of nursing, doctor of physical therapy, doctor of education?
Because it's wordy and it doesn't fit in the title very well.
Yeah, okay. Well, I've seen people who have strings of things after their name, strings of letters after their name. They can fit that, you know. I people who have earned a PhD, I think, in the context of their vocation, should be able to use that honorific. It's hard earned.
Yeah, I think so. Yeah, my
I
take
would
on
hope
it
that
too
she
is like
I mean,
let's
I would
look.
hope that she wouldn't use it in a clinical context because it's an academic title, right?
Oh, and help
And
me.
I
What's a clinical context is when you're in a hospital, or what do you mean?
yeah,
Right. Yeah, I'm a doctor. Everybody, I'm a doctor. Okay. Well, it strikes me as what it's just obvious what she's trying to do, which is a good thing. She's gonna be a leader, and she's gonna be crazy visible, and she's trying to let the world know that she's not a lightweight, and she's earned it, and that just strikes me as let her. That's normal. I'd want it
agreed.
if I was a PhD. Wish I was.
Agreed.
Uh, before I ask you about hope, is there anything that we didn't cover that I should have asked you?
I don't think so. I don't think so.
There's no rules,
No, I don't think so. We talked about a lot.
including Netflix and Outlander. Dr. Wendy Dean, here we are, 2020. There's a pandemic. What gives you hope?
Um, a lot of things. The people that I work with, the people who are on the front lines, they really they are amazing. They give me hope every day. They keep putting one foot in front of the other. They keep doing the right thing for their patients. More and more administrators are starting to give me hope because they're realizing um, that maybe a change in approach is called for, and so that's giving me hope. Um, yeah, I think as thin as the silver lining in the pandemic may be, I do think that there are some powerfully important things that it's taught us, that and we have the option to make different choices coming out of it. And I hope we do that.
Nice. Does seem like different careers are in vogue at different times. So right after 9/11, nothing was cooler than being a fireman. And right now, I think because we're seeing those incredible videos on social media, caregivers of all types are just, you guys are the stars right now. And good.
Yeah.
We love you. Don't give up.
Thanks. We won't. We'll try our best. Wear a
Uh,
mask though, for God's sake, will you? Please, people, wear a mask.
yeah, okay. Thank you. Wear a mask. Uh, yeah, gosh, I'd love to ask you a million things about COVID, but I don't want to take advantage of it. It's called fixmoralinjury.org. We've got Dr. Wendy Dean. I heard you talk about Simon. I know one of the peeps you're working with is Elizabeth Holman. who is
Yes.
a common pal, and she's the reason you and I are connected. My name is Brad Montgomery. I'm so grateful you're here, Wendy. Hold with me, but everybody, thanks for being here.